Dear colleagues, I have to say I feel very honored to be here today, and I would like to thank Dr. Cosmidis not only for inviting me here, but also for accepting me here in her department, where I have to say I feel very warmly accepted. And also I want to say that the high professional level of her team makes that I don't miss Rome, not even Paris. So we are here today to talk about the recent advances in diagnosis and treatment of pediatric brain tumors. And I would start saying that in the last decades we have assisted to major progresses in the understanding of the human genome. So we have to think that we have passed from the study of single genes in the 70s, and we are now facing the possibility of sequencing the whole genome with the whole genome sequencing techniques. And only 10 years ago, sequencing a human genome was costing something about $100,000. To date, in 2015, with only $1,000, we can sequence the whole genome. So the economical issue is no more an issue, but the problem is that we are submerged of new data, which we can imagine like a sort of tsunami of data, that we are not always ready to understand, to interpret it, and also we need supercomputing infrastructure with high-performance storage in the order of terabyte, and mainly, above all, we need skilled people in other domains like in bioinformatics, biology, molecular biology, and of course, oncology. So we have learned now many things about the cancer genome landscape, and if we think about the adult cancer, like here, for example, I took the colorectal cancer. We know now that, thanks to this whole genome sequencing, there are around 90 mutated protein coding genes per cancer, per tumor, per type of tumor, and around 11 recurrent mutations per single tumor. And here we have the landscape of colorectal cancer, where we can see the few mountains, which are the most frequent mutated genes, like the APC, KRAS, TP53, and many small hills that are the less commonly mutated genes, but that are still there. And we know now that in adult cancer, we have a multi-step genetic model of tumorigenesis occurring over several decades. Well, in children, the scenario is completely different. And if we compare adult cancer with the pediatric cancer, we can see that we can see that in adult cancer we have an average of 60 mutation in driver genes, and at the contrary, in pediatric cancer we have around only 10 mutated driver genes per cancer. Here we can see the medulloblastoma with these 10 mutated driver genes compared to the 60, 70 mutated driver genes of the colorectal cancer. So a completely different mechanism of tumorigenesis. Now, we know that pediatric brain tumor are the second most frequent tumor in pediatrics, just after the leukemias. The most frequent cancers, pediatric brain tumors, are the low-grade glioma, then we have the high-grade glioma, and then we have the medulloblastoma. So let's start with the pediatric low-grade glioma, which are the 50% of pediatric brain tumors. The most frequent subtype is the Pilocytic Astrocytoma, which is mainly located in the optic pathways, and which has a very high overall survival of more than 90% at 10 years. Well, these are tumors that have a very heterogeneous clinical evolution, because in some patients we have prolonged periods of growth arrest, and in some other patients we have continuous progressions. They almost never progress to high-grade glioma, at the contrary of what happened in adult low-grade gliomas. The treatment rely on surgery whenever feasible, and mainly on chemotherapy. And we try to postpone the radiotherapy in the for older ages. The response rate to chemotherapy is 40%. So we know that in some cases, the low-grade glioma can occur in the context of a genetic syndrome. We know that 15% of low-grade glioma occurs in the context of neurofibromatosis type 1. We can have subependymal giant cell astrocytoma in the tuberous sclerosis syndrome. And we have some reports of Noonan syndrome with the low-grade glioma. So what do they have in common, all these syndromes? They have in common the abnormalities in the MAP kinase pathway. Here we have the neurofibromin, which is altered in the neurofibromatosis type 1. Here we have the tuberous sclerosis complex, which is alterated in the tuberous sclerosis disease. So in the very recent years, the biologists, the oncologists, the scientists decided to focus on this MAP kinase pathway in order to better understand the tumorigenesis of these tumors. And indeed, they discovered that in the pediatric low-grade glioma, in many, many cases, we have abnormalities in this BRAF protein. BRAF gene duplication constitutes a mechanism of MAP kinase pathway activation in pediatric low-grade astrocytoma. In the majority of the cases, we have a duplication of BRAF, and the duplicated genes fusion with another gene that in the majority of cases is the KIA 1549. In this fusion, the gene that is produced codes for a protein who lose the regulatory domain and keeps only the kinase domain. So what happened is that this protein, the BRAF protein, is constitutively activated. So the MAP kinase pathway is constitutively activated. This is just to show you that we have alternative kind of fused genes where BRAF can fusion with different exons of KIA 1549. This mechanism of duplication and fusion is very common in the pilocytic astrocytoma. In another subtypes of low-grade glioma, which are the gangliogliomas, we have another kind of abnormalities, always in the BRAF gene. Here we have duplication and fusion. Here we have a point mutation. And actually, this is the same mutation that we find in a melanoma patient, is the BRAF V600E mutation. And both leads to the constitutive activation of BRAF kinase pathway. This figure is just to show that the incidence of BRAF duplication changes according to the location, with a higher incidence here in the cerebellar location. And this is to show you that the abnormalities in the MAP kinase pathway are mutually exclusive in pediatric low-grade gliomas, which means either we have the mutation, either we have the duplication, either we have the neurofibromatosis gene abnormalities. We don't have the BRAF mutation and the duplication and the mutation in neurofibromatosis gene. So two very recent studies with the whole genome sequencing have studied the patient with the pediatric low-grade astrocytoma, and here again they have definitively stated that it is a single pathway disease, because all these abnormalities, so the KIA-BRAF fusion, which is the most common, other kind of BRAF fusion or BRAF mutation, or all these mutations, they all occur in the MAP kinase pathway. And we have a median number of non-silent somatic mutation and structural variation, which is 1 per tumor. So with only one mutation, we start the tumorigenesis in these tumors. So how can we translate all this knowledge in a clinical benefit for our patients? So there is some optimism. Here I show you the results of a study published in New England, where patients with tuberous sclerosis and subependymal giant cell astrocytoma have been treated with everolimus, which is an mTOR inhibitor, so an inhibitor of the MAP kinase pathway. And here we have the response to the treatment with the shrinkage of the tumor after only 3 months of treatment. Here again, rapamycin, another mTOR inhibitor in a sporadic low-grade glioma. Here again, the response to the treatment. Here we have the brief report of a few cases, 4 cases of gangliogliomas with the BRAF V600 mutation, which, in parentheses, it's very easy to detect with a simple immunohistochemistry, treated with vemurafenib, which is the same drug that is used to treat metastatic melanomas. And here we have the response of the glioma after 4 months and 19 months of treatment. So there is some optimism, but there is also some bad surprise. Here there are the results of a phase 2 trial with the sorafenib, which is a multi-target new compound who has as a main target the BRAF, which has been used to treat recurrent or progressive low-grade astrocytoma. So we were expecting brilliant response, and we found this kind of Kaplan-Meier, which shows a high percentage of progression after only 3 months of treatment with sorafenib. And this is very unusual for low-grade astrocytoma, where generally we have a stable disease or response to treatment and very few progression, but with even the progression, they are not like this. We have a higher percentage of progression-free survival. And here is the MRI, where again we see the progression of the disease after 3 months of treatment. So a very bad, unexpected surprise. And the hypothesis is that when we block one of the steps of the pathway, the tumor cell is able to escape the blockade and upregulate the same pathway from another side. So probably we will need to act on several targets or to go lower in the cascade. So now we move with a few slides on the high-grade glioma, which are the malignant counterpart of the low-grade glioma. In children, we have mainly glioblastoma, anaplastic astrocytoma, and diffuse intrinsic pontine glioma. In this tumor, the complete surgical resection is virtually impossible because they are very infiltrative tumors. And treatment rely on surgery and radiotherapy, which is the gold standard. And generally, we add also some kind of chemotherapy, and which generally is temozolomide and recently even bevacizumab. But we have a very dismal prognosis with less than 5% of patients alive after 5 years from diagnosis, and almost half of the patients dying after 1 year from the diagnosis. So the recent insight in the molecular biology of this tumor seems to show that pediatric high-grade glioma are an epigenetic disease. When we say epigenetic, we refer to all these changes in the gene expression or cellular phenotype that are caused by mechanisms other than changes in the DNA sequence. So we are not talking about mutation in the suppressor gene or in the oncogenes, but we are talking about mechanisms like, for example, the DNA methylation, histone modification, expression of microRNA. Here, just to show, just to remind briefly, that the DNA is wrapped around the octamer of histones, and that the degree of compaction of the chromatin is responsible for the accessibility of the gene. So when the chromatin is compacted, the gene is not accessible for the replication and transcription. And at the contrary, when the chromatin open, the gene become accessible and it can be transcripted. And in case of histone trimethylation, the chromatin is compacted. So one mechanism that we will see is that the demethylation or the hypomethylation leads to the opening of the chromatin and the expression of some genes that are normally not expressed. So in pediatric high-grade glioma, we have recently discovered that in almost 50% of tumors, we have a mutation in the H3.3 gene responsible for the coding of the histone 3.3. We have two variants of the H3.3 protein mutated, the K27 and the G34. Both give a loss of trimethylation, which lead to the fact that usually silent genes become expressed, and this leads to the cell transformation. It's interesting to note that the K27 mutated variant is present in the brainstem and midline tumors, whereas the G34 is more in the cortical tumors. So we can divide the high-grade glioma in 6 groups. Here we have the K27, which is the prevalent form in children high-grade, in pediatric high-grade glioma. And we also have the PDGFR-alpha amplification, also present in pediatric tumor and to a lower extent in adults. Here we have the EGFR amplified tumors, which is the classical adult tumor, and we don't find this kind of mutation in children. Here we have the EDH mutated tumors, which have a better prognosis. So clearly, we have different entities, and especially I want to stress the fact that pediatric tumors are not the same of the adult tumors. And this becomes even more evident when we talk about the high-grade glioma in infants. In children less than 5 years with the high-grade glioma, we have a progression-free survival at 5 years of 35% with chemotherapy only, without radiotherapy. And even we can rescue these children and obtain 60% of overall survival when we treat them at progression with radiotherapy. So clearly, it's a different clinical entity. And this is confirmed even from the biological point of view. Here we see that in infant high-grade glioma, we have less chromosomal alteration. Red are the gain, blue are the loss of chromosomal material. And so we have a more stable genome compared to the pediatric high-grade glioma in older children. Also, more in detail, we see that in infants, we don't have the H3.3 histone mutation. We don't have the PDGFR alpha amplification. And in 27% of cases, we have a loss of SNOR, the gene which is implied in the RNA splicing. Now, if we move to the medulloblastoma. Medulloblastoma is the embryonal, very malignant tumor of the cerebellum. And in 30% of cases, the patient presents with the leptomeningeal dissemination at the diagnosis. We have 3 histopathological subgroups, which are the classic medulloblastoma, the desmoplastic nodular medulloblastoma, and the anaplastic or large cell medulloblastoma. We used to stratify the patient according to clinical prognostic factors, which are the age, the metastatic status, and the extent of resection. But very recently, we have added also the histological criteria, and we divide the patient according to the histopathological variants. Here we see the Kaplan-Meier of the 3 groups of patients, and we see that desmoplastic medulloblastoma have a better prognosis and a better overall survival compared to the classic, but especially compared to the anaplastic medulloblastoma, which is the more malignant variant. So according to this criteria, we divide patient in standard risk and in high risk. And of course, in standard risk, we can treat the patient with the standard conventional chemotherapy and reduced dose of irradiation, whereas in the high risk, we can even recur to the high-dose chemotherapy with the autologous bone marrow transplantation and, of course, full dose of radiotherapy. Of course, we have many concerns about the long-term sequelae of our treatment. Mainly, we are concerned with the neurocognitive outcome. Here, we have 3 different pediatric brain tumors. Here there are the astrocytomas that are just operated and not irradiated, where we have a very good IQ score. Here we have the ependymomas who are operated and irradiated, but only on the posterior fossa. And here we have the medulloblastoma, and we can see how the IQ score decreases progressively with time, mainly because of the radiotherapy, but probably also because of the surgery. We also have concerns about the impairment. Here we have 2 twins brothers. Of course, this is the one with the, that has been treated with the medulloblastoma. And then, of course, concerns about hearing loss and more and more concerns recently about second cancer. What's happened here? Okay, so there is an urgent need to even better stratify these patients, trying to de-escalate the treatment in some groups and intensify the treatment in other groups. What we have learned from molecular biology recently is that, and which have given a consensus, that there are 4 groups of medulloblastoma according to the molecular pathway that is alterated in the tumors. And we have also a different distribution of these groups according to the age. So, first of all, we have the WNT subgroup in 10% of the patients. We know that medulloblastoma can occur in Turcot syndrome, which is due to the mutation of the APC gene, which is part of the degrading complex. This is a degrading complex which degrades the beta-catenin. But we know now that in 10% of the patient we have a mutation in the CTNNB1 gene, which is the gene which code for the beta-catenin. And this mutation leads to the stabilization and nuclear localization of the beta-catenin, which goes to the nucleus and acts as a transduction factor and induces the cell proliferation. These tumors arise from the dorsal brainstem, and very interestingly, they have a very good prognosis. And here we have the 2 Kaplan-Meier. Here we have tumors with the positive for the beta-catenin, and here we have tumors negative for beta-catenin. And I want to stress this because this is information that it's very easy to obtain, because we can have this information only with a simple immunohistochemistry. Here we have the sonic hedgehog subgroup. We have perturbation of this pathway in 30% of patients. We know that medulloblastoma can occur in Gorlin syndrome, which is due to mutation in the patch gene or in the SUFU gene, with the consequent activation of the pathway. And these tumors arise from the external granule cell layer. They have a bimodal age distribution because they are present in infants and in adults. It's interesting to note that the desmoplastic variant is restricted to this group. The overall survival is around 60–80%, so intermediate prognosis. And in the last here, there are clinical trials which are studying which have introduced the use of SMO inhibitors. I've lost completely this. Okay. Okay. Which try to block the cascade acting at this level. And here we have a case of one medulloblastoma relapsed. Here we have the relapse, and treated with this compound, which is a SMO inhibitor, and we see the regression of the tumor and the complete response. It's interesting also to see that the MRI picture is different if we have a sonic hedgehog medulloblastoma, which is far from the brainstem, or a WNT medulloblastoma, which is stick to the brainstem. So I said there is a consensus now in dividing the medulloblastoma in 4 categories. So we have the WNT, we said very good prognosis, rarely metastatic. The sonic hedgehog, bimodal distribution of age, intermediate prognosis, uncommonly metastatic. And here we have the group 3 and group 4, which share the MYC amplification, which are frequently metastatic and which have a very bad prognosis. Also important to say that even the information about the MYC amplification is very easy to obtain with only the simple immunohistochemistry. So the beta-catenin and the MYC are 2 basic information that we should have and that are very easily, we don't need the whole genome sequencing to have this information, but just a simple immunohistochemistry. So this information will help us to better treat our patient. And now we are talking of future protocols where we will probably, the next COP-PNET5 protocol will de-escalate the treatment in the WNT group, where we found the nuclear expression of beta-catenin. In the sonic hedgehog group, if we have infants with the desmoplastic variant, we will treat them only with chemotherapy, and we will eventually consider to introduce the SMO inhibitor, and we will treat older or adult patient with standard radiochemotherapy protocol, and also we will consider the SMO inhibitor, while for the group 3 and group 4, we will go to intensification of the protocol and try to find other target therapy. So there is some optimism coming from these studies, because we will be probably able to better treat our patients, to improve their prognosis, also moving toward a more personalized medicine. Thank you very much.